Okay, so we're going to start off as NET 101, Neuroendocrine Tumors 101, and we couldn't have a better speaker to kick off this conference. He is George Fisher, physician, PhD, and associate professor of medical oncology and director of the Cancer Clinical Trials Office at Stanford University. You have his bio with his credentials in your booklet. I just want to add that he is an unbelievable leader in this field on National Cancer Institute task forces. He's on the executive committee of the North American Neuroendocrine Tumor Society. And most importantly to us, he is the co-chair of our Board of Scientific Advisors and just a wonderful, wonderful physician. So please join me in welcoming Dr. George Fisher.
Well, good afternoon, everybody. I know from the hands that were raised, some of you effectively already have your PhDs in this, and some of you newcomers. So if you came to understand more about your specific disease, I'm afraid I'm going to disappoint you. What instead I'm going to do is try to put neuroendocrine tumors into perspective throughout the broad context. So this is going to be painting with a broad brush so that you might better understand the terms that are applied to your disease and how it fits in with the many other diseases that are within this neuroendocrine envelope. What I will not be discussing, and I've done this often enough that almost every session that have 100 more people, there's somebody here who maybe shouldn't be or is going to be disappointed because the information will not apply to their disease. And that's our fault, not yours. I will tell you that we're not going to be talking about small cell neuroendocrine lung cancer or large cell neuroendocrine lung cancer. Those are entirely different diseases, not related to any of the things that we'll be talking about here, but the nomenclature can be confusing. We're not going to talk about colon cancers or adenocarcinomas with neuroendocrine features. Those are just bad colon cancers. Those are not neuroendocrine cancers, strictly speaking. And then there's another term that I'm sure Ed and I are both in dismay about. We've been trying to get pathologists to change their terminology, but they insist on calling a certain subset of appendiceal cancers goblet cell carcinoids. Those are not carcinoids. So if you have any of those diagnoses, I hope you enjoyed the lunch, but everything else that's said from here on out will have nothing to apply to you. And you should talk with Ed afterwards because he can set you straight on that. So net history, just one slide on net history. It was Siegfried Oberndorfer, who, here's that gentleman right here, a nice color photo from 1907. He first described carcinoid as a term that was not quite carcinoma. And so oid in Latin or Greek means kind of like. We all use oid liberally. And so this is kind of like cancer, but not exactly like cancer. And hence, right from the start, there's been sort of this dilemma. Well, is it benign? Is it malignant? If it's malignant, how malignant is it? And when does somebody deserve the cancer diagnosis versus a benign diagnosis that's something short of malignancy? So right from the start, right from its inception, it's been a little bit confusing. It's also one of the rare omas. Oma is Latin for tumor or mass, and so there have been a number of articles talked about rare omas, or all those things that occur so rarely that they're hard to study. And the incidence is indeed low. If you look at the number diagnosed per 100,000 people, it's only about 5. 5 per 100,000 people. These are all the different types. Added up, it's 5. Now, what does that mean? This year, 1 in 2 men and 1 in 3 women can be expected to have a cancer diagnosis in their lifetime. That's huge, and we're talking about 5 in 100,000. So this is very low on the cancer hierarchy in terms of incidence. But it's really not that rare, because if we think about prevalence, and prevalence is the number of patients with a disease at any given time. So it's not the number of new patients diagnosed per year, it's the number of patients who are in the population. They may have been diagnosed 10, 15, 20 years ago, or they may have been diagnosed last week. That counts in prevalence. And it turns out that if you looked at prevalence, there's actually more cases than stomach and pancreas combined, and I would contend that these data are at least 10 to 15 years old, and right now I would bet that we have more neuroendocrine patients in our population than there are stomach, pancreas, esophageal, and hepatobiliary combined. So it's not that rare a tumor. There are a lot of people walking around town with neuroendocrine tumors when you think about these. Now, of course, the reason for that is very simple. People live longer with neuroendocrine tumors than they do with stomach, pancreas, esophageal, and hepatobiliary cancers. Now, you also heard in Ron's introduction that the incidence is increasing. So we're seeing more every year. That wasn't always the case, but I'll tell you that right back here with that term carcinoid and our technology or our tumor registries basically told the tumor registrar at every hospital that was counting cancer patients to only count it as a cancer if it said on the pathology report cancer or malignancy. If it said carcinoid, it wasn't counted because people didn't know whether it was a cancer or not. And so we're missing a lot of data from back here, and so the data was kind of flat. You'll notice a big blip here. Does anyone know why there was a big blip? Or why all of a sudden in 1984 to 86, the number of cases doubled? No, that's a good point. It was partly definitional. The reason is that's when octreotide came along. So if you have a treatment, then you can start looking for the disease. And now we started inspiring pathologists saying, hey, look, we can do something for these patients now. Let's look at all those patients who had tumors that we couldn't classify before and see if they actually have a neuroendocrine tumor. And if they have a neuroendocrine tumor, maybe they would benefit from this new treatment. So I think that's in large part due to having a treatment all of a sudden and getting attention. Now this curve here, it's not like we're having an epidemic. It would seem so. Now I put this red curve, which is 1, 2, 3, 4, and 5 per 100,000, next to this blue curve, which actually belongs on this axis, which is a 100, 200, 300, 400, 500 per 100,000. This is all other cancers. And you can see that it was peaking until 1992, and then that's actually come down somewhat, while this is still going up. The reason this is still going up in large part is not because there's an epidemic of cancer, of neuroendocrine tumors, or because there's a virus that causes these, or it's because of some environmental exposure. There may be minor contributions of environmental factors, but this is primarily from the fact that we're actually doing more scopes. We're looking more for colon cancer, and guess what? If you look for colon cancer, every once in a while you're going to find a small carcinoid. We're also doing more CT scans, so we're finding things that we would not have otherwise have found as quickly. So that's largely responsible for this. The nomenclature has been particularly difficult. I already alluded to that the cancer registries didn't even include carcinoid uniformly, unless the pathologist happened to put down the word malignant or cancer. And it's because there are a bunch of different names that have been used for this disease. Apodomas, which stands for this, GEP nets, islet cell carcinoid. This is the one that stuck. In fact, I don't know if Ed, if you were part of this, but I was part of a group that tried to get rid of this word. We want to get rid of the word carcinoid because even that was confusing. And I think that we're stuck with it. Now we're just trying to use the carcinoid term more carefully in specific instances so it doesn't get abused. So this nomenclature has evolved, and it's evolved to a point where now it's rather simple. We define the organ of origin, so we say, well, this is a neuroendocrine tumor of the ileum or of the appendix or of the pancreas. We say what it's making. Well, this is making insulin, or this is making glucagon, or this is making gastrin. We say whether there's a syndrome associated with it. That is the person having symptoms from whatever is being secreted? If it's an ileal tumor that's making serotonin and you have carcinoid syndrome, we say, well, that person's having a functional carcinoid tumor or carcinoid syndrome in association with their tumor. Not everyone who has a syndrome who has a tumor. Okay? And so we can measure some of these things, but more importantly, we just ask the patients, are you having flushing, are you having diarrhea, are you having rashes? And perhaps most importantly, and difficult to get our hands around sometime, is what it looks like under the microscope. Is it well differentiated or is it poorly differentiated? Is it low grade or high grade? Those give us biological clues as to how the tumor will behave. And this category, poorly differentiated and high grade, behaves completely differently from the low grade, well differentiated. And as biology would have it, every once in a while there's a gray zone. The grade 2 is sometimes in between. So let's talk a little bit more about the biology of neuroendocrine tumors. These are derived from neuroendocrine cells. So what's a neuroendocrine cell? Neuroendocrine cells have the capacity to make hormones. Hormones are defined as just something that is a molecule that a cell makes over here, And the molecule travels via the blood or some other process over here where that hormone attaches and changes the behavior of a second cell. So it's sort of a messaging system in the body where a message will be put in the blood and, and be released from one place and have an impact someplace else. That's what hormones are. And sure enough, neuroendocrine tumors can release hormones that we all know can have implications for the gut, and the gut will start secreting, and people have diarrhea, or can have the flushing symptoms. So these are due to the hormones that are released by this tumor. They're not sex hormones, they're not steroid hormones, they're small peptide hormones. The neuro is because there are some linkages of these to nerves, and perhaps it's not surprising then that sometimes anxiety or stress can precipitate some of the release of these hormones. Now, if you imagine that this is a neuroendocrine tumor cell, let's say it's a carcinoid tumor cell, and this is the top of it, and this is the body, and it's got these receptors that allow it to communicate with the world outside. Oddly enough, cells have to communicate with the world outside, and they usually do it through receptors that go across the cell membrane, and this receptor implies that it can bind to something, and it can bind to any hormone coming through, binds to it, and that binding has a biological effect on the cell. So it turns out that 80% of neuroendocrine tumors have these somatostatin receptors, or SSTRs. And it turns out there are 5 SSTRs, and the most common one in neuroendocrine tumors is SSTR2. And if you imagine that this is 1, 2, 3, 4, and 5, cells can have all 5 of them, or some can have more of SSTR2 than 3. It turns out that the somatostatin receptors bind to, guess what? Somatostatin. And somatostatin is a hormone in the body that your body uses to turn on secretion. And it turns on secretion in the gut, it turns on secretion in the pancreas, it turns on secretion in lots of different places. But it's not a very good drug, and octreotide is just sort of a man-made version of somatostatin that acts over a longer period of time, is more stable, and therefore it can work as a drug to bind to these receptors and actually block them or change the behavior of the cell. Just one slide on genetics. I think there may be some more discussion of this further on, but there are familial genes, they're quite rare, but they're familial genes that can predispose towards certain types of neuroendocrine tumors. But then more interestingly and more recently, there are tumor genes. There are genes that we can find within specific tumors that may be clues as to how that cell became a cancer, number one, but more importantly, may give us clues as to how to treat that cancer, number two. And so just recently in the pancreatic neuroendocrine world, there are PTEN, TSC mutations, DAX, ATRX, MEN1, and CDK4/6 amplifications. These are lots of gibberish, but I will tell you that we have drugs that can target these two, and we have drugs, new drugs that have not yet been approved but will soon be approved, probably the first one in breast cancer, that will target these. And so we may steal from the breast cancer world and apply it to patients who have this particular defect in their tumor, if we find that defect. So we're really starting to delve into the genes or the genetic alterations that actually give rise to certain types of pancreatic neuroendocrine tumors. Applying the same sort of strategy in searching for genetic alterations, we've looked at midgut carcinoids, small bowel, ileal, and appendiceal carcinoids, and frankly, we've had trouble finding reproducible genes. And the first genetic defect that has been discovered will be published in the next few months. And I just found out about this at our meeting in Washington, D.C. And it may be something that we can target with the same drugs that target CDK4 and 6. So there may yet be new treatments on the horizon that still require some laboratory validation, but may lead to a clinical trial specifically targeting the molecular vulnerabilities of carcinoid. So let's talk about the clinical tendencies of the tumor. I mean, how does this tumor behave? We just mentioned a little bit of biology. How does it behave? Well, I never like to start a conversation with a patient and say, well, this is a slow-growing tumor. Because, you know, if you're sitting in the chair next to me, it's never slow enough, right? And I've seen so many oncologists get so excited to walk into a patient's room and say, hey, great news. You know, you could live 5 or 10 years. That's not exactly good news, but they're comparing it with pancreatic adenocarcinoma where you might live 5 or 10 months. And so it's really important, I think, for us to have a full appreciation that, yes, slow doesn't mean that we should ignore it. Slow doesn't mean that it's not important. And although it's slower than some of the other cancers, And yes, I'd rather have a pancreatic neuroendocrine tumor than a pancreatic adenocarcinoma. It's still a serious disease, and we just have to figure out how to treat it. And because of the term of slow growth, that's where we got the kind of like cancer, not quite carcinoma, but kind of like carcinoma. And sometimes they grow so slowly that treatment's unnecessary. And I was just having a conversation before lunch. I will let you know of the second person I saw as a faculty member at Stanford who came to me from the valley and near Fresno, a wonderful guy who just retired from his teaching job. He just turned 65, he was excited to get on with a retirement life and with the grandkids. And he ended up with abdominal pain, went into the emergency room, had a CT scan that looked horrible, had a laparotomy looking for something to fix, and they had to do a bypass because there was tumor everywhere in the liver and the abdomen. Terrible story. He was told that it's cancer, and he comes to Stanford for a second opinion. And he looked pretty good. I said, well, let's review the pathology, which is what we always do, and let's figure out what kind of treatments we can give you. We reviewed the pathology, and it was carcinoid, not carcinoma. So I said, well, maybe we don't need to treat this quite yet. Why don't we just get another scan in a month? We did, there was no change. And he's feeling pretty well. The bypass worked well for him. I got a scan 3 months later, there's no change. I got a scan 6 months later, there's no change. I've been seeing him for 18 years. And if you go back 5 years ago, I can see a change. But at each incremental scan, there's no change. Now that's a little bit on the extreme side, but that's how slow this tumor might sometimes behave. And if I had given him treatment 18 years ago, I'd be taking credit for it now because he would have been on treatment for 18 years. But it's really the nature of the biology of the disease. Some tumors grow so slowly that they don't really need treatment. And the exception, the really devastating exception is the poorly differentiated neuroendocrine tumors, which can behave like bad cancers. So what are the clinical tendencies? Well, as I already mentioned, these tumors tend to release amines or peptides or hormones into the blood, and those hormones can be used, if we can measure them in the laboratory, they can be used as tumor markers. And if they cause symptoms, then they're called secretory syndromes, or that's the term we use when they're functional tumors. Functional tumors meaning, again, you have symptoms associated with the secretion of one of those hormones. Another clinical aspect that's always puzzled us is that they tend to be very hypervascular. What does that mean? It means it looks like they have a lot of blood vessels. And it turns out they have a very rich arterial blood supply when we compare them with other cancers. And here's a good example of that. Here's a patient of mine with colon cancers, and this is the liver. So this is a person lying down on their back. Here's the table. There's their backbone. These white things here are ribs, because when you cut a cross-section, so the patient's sliced like a salami, and the ribs go down like this, so you see a bunch of ribs at one time. This happens to be through the liver, so this whole entire organ here is the liver, a little bit of the kidney, spleen, and stomach. And these dark spots are tumors in the liver. That's what it looks like for colon cancer, that's what it looks like for breast cancer, that's what it looks like for lung cancer, pancreas cancer. They all look dark. For neuroendocrine tumors, they're bright like little light bulbs. They brighten up when the contrast is in the arterial phase. If I took a scan of this particular person, 2 minutes later, you might not see these spots, because just as quickly as the dye is in the artery, it goes into the veins, and then you don't see it in the tumor anymore. So it's a very peculiar tumor in that very rich arterial blood supply. And here's another example. These are, of course, tiny, tiny multiple spots, and these are larger spots. They still have that very hypervascular, meaning they're more white because of the IV contrast that we use. And here's a major artery in the body, the aorta. That's bright white, and you can see that's taking up all that whiteness. So there are clues about the biology and possibly even clues about what treatment would be best. So what else about the clinical facts of NETs? Well, whenever we have a cancer, no matter what the cancer is, we try to ascribe it a stage. And almost all cancers are stages 1, 2, 3, and 4. And some of the staging systems are exceedingly complex. Frankly, I don't even pay any attention to the stage. I try to teach our fellows to study the stage before they take the boards, but otherwise, when I'm seeing a patient in the clinic, I don't really concern myself with the stage. What I concern about is where is the tumor and can it be removed? That's all I need to know. Even if it's stage 4 If it's spread to one spot in a site that's easily removed, I might say, well, let's go ahead and take it out. So stage has less importance in the day-to-day practice of dealing with neuroendocrine tumors than it does with many other diseases like breast cancer and colon cancer. In terms of grade is what the pathologist looks at in the microscope. Grade defines how the cells look and how biologically aggressive they look under the microscope. And so it also looks at how many cells are in the process of dividing. So if you look at 500 cells in the microscope and you see none of them are in the process of actually dividing versus another sample where 50 of them on the process of actually dividing, that means that tumor is more likely to grow because more cells within that population that you're looking at are actually in the process of growing. And so that's an important way of defining whether this is going to be a low-grade or a well-behaved tumor or a high-grade or a poorly behaved tumor. There's another trick that we use. We use a stain called Ki-67, which happens to stain the proliferating cells, even if they don't happen at that moment to be dividing. So we can use the Ki-67 as a surrogate for proliferative potential. So stage, again, 1, 2, 3, and 4, and all the subsets. It is important in the academic world because that's how we report patients to tumor registries. It's not as important when I'm sitting down with the patient in front of me. I want to look at the scan and say, well, it's stage 4, but I can remove that cancer. Let me send you to this surgeon over here. Now let's say that having understood a little bit about the biology of this disease, can we take advantage of it? I already mentioned to you that the slow growth offers us an unusual opportunity in cancer to not treat. And this often befuddles people because, well, doctor, I have disease in my liver and my lymph nodes and my abdomen, and you're not treating me? And I said, well, let's just wait a few months, and if there's a change on the next scan, then we'll go ahead and think about treatment. But if there's no change, I can't make you feel better if you're already feeling well. And if the tumor's not growing, I don't get any credit for my toxicity I give you with a treatment. If the toxicity is if the drugs are meant to keep the tumor from growing, it's not growing anyway. So I think that appreciation for observing tumors is something that we, like Ed Wolin and I, who see a lot of patients with neuroendocrine tumors, can get. The people who see a neuroendocrine tumor every 3 years, it's hard to know that. And it's hard to be so sure that you shouldn't be treating that person. So I think that part of what we talk about is trying to not be so quick to jump on these new drugs, but to think carefully about whether the person actually needs treatment. Sometimes we will treat when there's a very extensive disease or there are symptoms associated with a tumor. We'll go ahead and say, well, if I can give you a treatment and shrink the tumor, then maybe I can relieve some of those symptoms, and there's clinical value in that. Also, we always consider treatment when we've had the opportunity to observe a significant growth rate of the disease. If the tumor's doubling every 3 months, even if the person feels well, we say, well, we better get on board right now and try to keep that tumor from growing further. So those are the criteria that we use in large part to determine who should get treatment and who shouldn't. I also mentioned, of course, that we have somatostatin receptors, and because these things hone right to the tumor, they're hormones that bind right to that receptor, bind there and stick there. We can use that to decrease secretion of peptides, which is why octreotide is used for carcinoid syndrome. We can use it to dampen growth, which I'll show you in a second, and Ed will probably talk about in the next talk. We can bind to the tumor and use it as an imaging agent. So we can bind a little bit of radiation to that octreotide, put it in the body, and let it go everywhere. It will stick to the tumor, and then we can use that. We can detect the radiation with what's essentially a Geiger counter. Or we can put a lot of radiation on. I know Ed's going to talk about this next, and that's called PRT, a very highly radioactive isotope on the octreotide-like drug. So it's a way of hand-delivering something right directly to tumor. So here's our friend here, the cartoon of the carcinoid cell with its somatostatin receptors on the cell surface. And it turns out that these different receptors, biology doesn't do things for no reason. Whenever biology confuses us, it's because we're not smart enough to understand it. There's always a reason why Mother Nature behaves the way she does. And so it turns out that some of these receptors not only control secretion, but they also control growth of the cell. And this is cell death. Some of these also help influence whether the cell should die or not. It's underappreciated that you can get a cancer by growing too fast, which is what most people think, But you can also get a cancer by not dying enough. It sounds silly, but if normal cells grow and die and then are replaced, if normal cells kept growing and didn't die, then the problem is you'd have more normal cells than you need and you have a tumor. So cancer can occur at both ends of the spectrum. You can either have insufficient death or too much growth. Carcinoid tumors grow so slowly, it's a combination of both. So these receptors help mediate some of that, and so not surprisingly, there's been a lot of research trying to target the different receptors and see if we get different outcomes. This is an example of an MEN1 patient, multiple endocrine neoplasia 1 patient, and those patients have a high propensity for getting pituitary, parathyroid, and pancreatic neuroendocrine tumors. And this is the octreotide scan. So this is octreotide, the same drug that people get for carcinoid syndrome, only it's linked to indium-111, which is a radioisotope that you can detect with a gamma counter. And they put this patient in a camera after giving that. And here's the patient facing us. You can see that this is the head, these are the shoulders, this is the body, and facing us. So that means that there's this big spot right up here. That's the pituitary. So this person has a pituitary tumor. There's a spot right there in the neck, actually 2 spots, so the person has 2 parathyroid tumors. There are spots right here. It turns out this person had tumors in the duodenum, in the first portion of the small intestine. That's what those are. And if you go up here, where you can barely see, at the bottom of the liver, these are spots in the liver. So this person has what is probably a pituitary tumor, parathyroid tumor, a duodenal cancer that then spread to the liver. And you can see that by merely tying the indium-111 to the octreotide and injecting it. So that's a striking example of an octreotide scan. As I mentioned, you can take advantage of the hypervascular nature. I showed you this picture of these bright light bulbs that turn on and turn off because they have such a rich arterial blood supply. It turns out that there's a process by which that arterial blood supply is formed. It's not just accidental. It turns out the tumor cells can make growth factors, almost like hormones. These are molecules that then go to a local blood vessel and stimulate receptors on the blood vessel. Now this is normal. This is the normal blood vessel. It's not a tumor. It's a normal blood vessel. But if it's inappropriately turned on and told to grow, then this blood vessel can then branch out and feed the tumor. This is the process of angiogenesis, or blood vessel formation. Tumors can't grow unless they get new blood vessels. And so it's been a hot research topic for a number of decades now. How can we interfere with this process? How can we disrupt this so that tumors can't get blood flow? And if you have a tumor that gets all this arterial blood supply, you got to figure out that this tumor gets an A+ in attracting blood vessels. It's really proficient at getting blood vessels there. What if we interrupted that? Well, this is sort of a cartoon of now, if you imagine that this is a blood vessel cell, an endothelial cell, not a tumor cell, but an endothelial cell, another receptor going through the membrane, and it responds to these various growth factors or hormones or whatever you want to call them. They're small molecules that can then stimulate through this receptor a series of events that lead the cell to grow, to expand, to grow new blood vessels. So that's the process. Well, there are different ways of inhibiting it. Let's just focus on this box over here. Bevacizumab, or sometimes known as Avastin, is a drug that's approved for lung cancer, colon cancer, briefly breast cancer, brain cancers, kidney cancers. And we know it works for neuroendocrine tumors. It's not approved for neuroendocrine tumors, but we know it works for neuroendocrine tumors. It binds to one of these growth factors and takes it out of the equation. That's all it does, is it gets rid of this. And if you get rid of this, then you can't bind to that, and you can't stimulate blood vessel growth. There's another drug, aflibercept, which got approved for colon cancer just last October. It does kind of the same thing. Or you can come in with an antibody. These are antibodies that bind to the receptor so that nothing else can bind. So you're blocking the ability of these growth factors to bind to that receptor, and that signal can't go on. There's a drug that will probably get approved this month or next month for gastric cancer called ramucirumab. This has not been tried in neuroendocrine tumors. Once it gets approved, we're hoping that the company will invest in some research on neuroendocrine cancers so we could see whether this might be a good drug and a way of inhibiting blood vessel growth. The third way is actually even simpler, and that's like cutting the wiring at the bottom of the switch. So you have this switch that you can turn on with these growth factors. But what if you just cut the wiring at the bottom of the switch? No more firing. You're no longer signaling. You can have all the growth factor you want, you can have all the receptor you want, but if you cut the wiring here, you stop it. The wiring here is what we call an enzyme. It's a tyrosine kinase. We have lots of tyrosine kinase inhibitors, and sunitinib was approved for pancreatic neuroendocrine tumors a year and a half, 2 years ago. Sorafenib, prosopanib, axitinib, vitalinib, a bunch of other drugs which do the same thing, all have activity in neuroendocrine tumors. They're not approved yet, and they're still going through the process of gathering that proof. So we have many ways of interfering with this cycle, and Ed will probably talk about some of the data that actually led to approval of some of these. So with all that, we have sort of a net treatment algorithm. And I think that it's always important to keep in mind that if you have what your pathologist has confirmed is a well-differentiated, you can kind of read in well-behaved, not always, but most of the time, well-differentiated, well-behaved neuroendocrine tumor. And if it's local, I'm running out of, there we go. If it's local or regional or resectable, and a good surgeon can remove it all, that's a straightforward treatment. You might not need it might be a cure, it might not be a cure. If it's not a cure, you might not need another treatment for 3 years, 5 years, 10 years, if it's a very slow-growing tumor. If it's spread and cannot be removed, but it's not causing any problems, you might just get a scan in a few months, and if that looks fine, maybe get a scan in 4 months. Do the same thing I did with the patient I saw for 18 years. And you might just observe until there's growth and then decide what treatments to pursue. If it's metastatic and causing symptoms or progressive, meaning it's growing, then you're stuck with chemotherapy. And then if it's localized, you might give a local chemotherapy treatment or a local therapy to the liver. Again, the liver is a common place for these to spread to. So that's sort of a general treatment algorithm without getting into specifics of types of drugs, because I think Ed's going to follow up with the specific therapies. How do we improve upon that algorithm? How do we kind of move the field forward? Well, let me just start by talking about some impediments to moving the field forward. One is that unlike colon cancer, breast cancer, lung cancer, pancreas cancer, we don't have many good tumor models. We don't have tumors that grow in mice reliably that we can test. We don't have a lot of pancreatic or ileal or appendiceal carcinoids that are growing in petri dishes that we can put a ton of drugs on or study their genes. There are a few, but they're suspiciously different from the normal situation, so we don't know how to translate some of the findings we have from the laboratory to patients. So there are a number of strategies around that, and a lot of research trying to come up with better tumor models. We also don't have a good database. It's kind of embarrassing that when you ask somebody about the data on a rare disease, that you can always say what we've done at Stanford, or what has happened at Cedars-Sinai, or what's happened at Mass General, or what's happened at MD Anderson. Everyone can look at their own database, but when you're dealing with a rare tumor, what we really want is a combined database. Now, we have a national cancer registry that's very helpful, and that generated a lot of the data I showed you at first in terms of incidence, but that doesn't give us the information we really want to have. It doesn't give us any tissue, it doesn't give us any biology, it just gives as a kind of a broad stroke of the incidence of those cancers. So if we really want to dive into this tumor and understand it better, we need to have a better tumor database. And it's long been theorized that maybe these electronic medical records will be able to talk to each other, but the truth is they don't. In fact, there are tremendous barriers to the electronic medical records talking to each other because of confidentiality concerns. So we've been unable to actually create the database that we'd all like to have. What's more is the tissue is scarce and sometimes discarded, and that's just a shame. So I would say that if you had a surgery and your tumor is in some hospital, guard that with your life, and don't trust the hospital to keep it. It depends on where you are. I suspect, Ed, here, all the tissue stays here forever, same with Stanford, same with any academic institution, but in the community, they might just throw it out after a few years. And that tissue might be very important someday. We also have clinical trials, but frankly, we have to enroll more people in the clinical trials. If we could double the enrollment in clinical trials, we could double the number of new drugs to test. Or more importantly, if we had a drug that was going to be successful, we could cut the time to getting that approved in half so that it would be available to everybody in the country. So it's really important to try to improve the accrual to clinical trials. And how do we do that? Well, we do that by converting discoveries in the laboratory to patients. And you can only do that through clinical trials. You can cure all the mice in the world, and it'll never become a drug until you do the clinical trials. Ideally, before you take it to clinical trials, you want to make sure that it works in a mouse. And I already told you that we don't have good mouse tumors for this disease, so that's one impediment. You'd like to see that it works in the cells in culture and tumors in mice, and that's safe in large animals. At the very minimum, that's what you need. Then you want to do some phase 1 tests to prove that it's safe in people and to understand what the best dose is. That's what a phase 1 study is. Usually a phase 1 study can take any type of tumor is eligible. You don't have to have a carcinoid or a breast or a colon cancer. Where the scientific objective of phase 1 is to understand the drug, its side effects, its pharmacology, how your body handles it. The intent of the patient treating you is always to give you a drug that has some potential for helping you, but the phase 1 study is really to understand the pharmacology of the drug. If we pass that and we think it looks good enough, we go to phase 2, and those are generally limited to specific tumor. So phase 2 trials are limited to specific tumors, and usually on the order of 25 to 50 patients, and sometimes these are even randomized, so you might have 50 to 100 patients in a randomized phase 2 study. And then if it looks good enough to compare in a larger data set, to compare to some standard and request definitive FDA approval, then you need to have a phase 3, and that's where you have a standard treatment versus an experimental treatment. Sometimes the dreaded placebo comes up, but in general, it's usually a standard treatment versus a standard treatment plus an experimental treatment. There aren't that many placebo studies. And this requires 200 to 500 patients and could take 2 to 5 years. It might take 10 years, and if we could accrue twice as many patients, it would only take 5 years. That's where the accrual comes in. I'm not going to go into the details here, but unfortunately, not everyone's eligible for a clinical trial. You might say, geez, I want to be in a clinical trial, but you might not have pathologic confirmation of the tumor. You might not have enough tissue available because it wasn't stored right, or you never had more than a needle biopsy. You might have the wrong kind of net for the trial. Your disease might be stable, and they might say, well, no, we're only selecting people who have growth of their tumor. And it's good not to be eligible for that trial because your tumor is stable. You don't need it. We measure success of a trial or drug based on whether it shrinks a tumor or whether the tumor grows, or whether it delays the time before the tumor grows. And then we look at overall survival, and most importantly, we look at the quality of life of the person that we're treating. Are we making their life better? So I'm going to close by giving a few slides about a net registry. Again, I just told you that we don't have a good database for this. We need a database. And there's a net registry that the Caring for Carcinoid Foundation funded a number of years ago for University of Pennsylvania, Dana-Farber, Memorial Sloan Kettering, Stanford, and MD Anderson. I get that right, Lauren? And Mass General Hospital, too. I think of Dana-Farber and them as brothers. And so so that was a nice seed funding to create a data registry, and that's actually still going on in each of the institutions. And we're all collecting the data. We're collecting a number of survey data. We're collecting the tissue. We're collecting blood. And we go ahead and consent people. We can consent people over the internet now. We can do it on an iPad. We get tumor registry questions surveyed. We get a blood sample, and we get the tumor tissue. Now, this is nice because you don't have to have had your surgery at Stanford. You can have had your surgery someplace else, and we can request the tumor be sent to Stanford for selected studies, or any place else for that matter. So that was started just a few years ago, and we have actually the first publication coming out on this. It's a small publication, but I think it's an important contribution that's coming out this year based on some data that we generated in 2011. So I think this has the opportunity to go someplace to actually improve the kind of biological material we need, the data we need. Because once we get this, this is a DNA scan. You can look at DNA expression. This is supposed to be the DNA. You can try to you can understand then what genes are turned on, what genes are turned off, what genes correlate with outcomes. We can't do that right now because in any single institution, you might have 50 patients or 100 patients where you have genetic information. If we had that at 15 different institutions and put it all together, we might actually be getting someplace. So in sum, there's been an explosive growth of net research. And how do we, the currency of success in academics, unfortunately, is not cures. It should be, but it's publications. It's they'll publish or perish. But you can see the number of publications going up dramatically, and the number of clinical trials. The clinical trials, I tell you, in 1995, and Ed, you may have been in the same boat, while I was at Stanford trying to get pharmaceutical companies to be interested in neuroendocrine tumors, I couldn't get a meeting with them because they said, it's so rare, why should we devote any research to that? Well, let me tell you, we have to beat them off with a stick now because there are so many companies with interesting drugs in their pipeline that might apply to neuroendocrine tumors and might get their foot in the door for an FDA approval because there are motivated patients such as yourselves who are willing to try those trials. So, and as a result, everolimus and sunitinib got approved, and octreotide before that, and streptozotocin. So there's been a big gap. This is 1976, I think. Octreotide is 1988. And look, 20-year gaps. These two drugs just got approved a year and a half ago, and there are plenty more in the pipeline. So I'm looking forward to changing that. So the take-home points is that research is booming in this area, much more so than anyone would have guessed 5 or 10 years ago. Numerous active and developing clinical trials. Look at it on the websites, ask your oncologist. And I really want to give my thanks and appreciation to all those people who have volunteered for clinical trials. I think it's huge. And I think that the horizon looks pretty darn good for this disease. So stay optimistic. Thank you very much.